Okay, so today we're going to talk a bit about drug resistance in cancer, why cancers are sometimes very difficult to treat, and why some are not amenable to therapy. So before we do that, it's worth considering some of the features of cancer cells that you've learnt about already, that perhaps answer the question of why we haven't cured cancer yet. So firstly, it's worth remembering that cancer is a term that groups many different disease types into a single classification. So unlike something like HIV, there's substantial differences between tumor types. There can be substantial differences in tumors that are actually of the same type. So what I mean by that is that one person's colon cancer can be driven by a very different mechanism to another person's, and they may require very different types of therapy, which is a bit of a challenge. The second thing is that there's actually common features of cancer cells that make them moving targets for therapy, which are concepts that you will have come across already, and you will come across them again later on in this course as well. It's worth remembering this feature that makes them moving targets for therapy. Okay, so if we just have a brief recap to start off with about the common features of cancer cells and cancer drugs that we use to target them. So firstly, you know from Andrew Ward's lectures that cancer is caused by gain of oncogenes. These are mutations that trick the cell into thinking it's receiving a proliferative signal all of the time. So it's like putting bricks on the accelerator of the car. And when this is coupled to loss of tumor suppressor genes, which are the usual brakes to proliferation and lead to repair of DNA and instruct the cell to die if it's sustained a lot of damage, then this makes the cell proliferate uncontrollably. So you lose those, you get much more cell proliferation. So cancer's treated in general by a mixture of conventional therapies. These include radio and chemotherapy, which target generic features of cancer cells. So for instance, radiotherapy induces lots of DNA damage, and cancer cells characteristically lose DNA repair enzymes. So the radiotherapy, by inducing lots of DNA damage, selectively targets the cancer cells because they can't repair that damage and they die, whereas the normal cells can and they survive. The other major line of therapeutics are targeted therapies, and these are rationally designed to target and correct the activity of certain enzymes that have gone wrong in cancer cells. Now, these are usually oncogenes. Now, the reason for that is that, in general, it's a lot easier to design a drug that inhibits something rather than to try and design a drug that replaces an activity or expression of a protein. Now we get on to the meat of the lecture, which is how cancer drug resistance arises. Now, drug resistance can arise because a drug might struggle to target all the cells in a tumor, and that can occur for a variety of reasons, and that includes the genetic background of the patient or because the tumor itself harbors particular mutations that make it difficult to treat. So resistance itself falls into two major classes, and the first is primary or innate resistance. And this is where the tumor cells are actually refractory to therapy from the outset. And the second is secondary or acquired resistance. And this is where the tumor becomes resistant to the drug during the course of the treatment or shortly afterwards. Now, it's worth reminding you that you're probably familiar with some of these themes from things in the news about antibiotic resistance, and those antibiotic resistance follows similar mechanisms. Okay, so if we just go through mechanisms or common mechanisms of innate drug resistance or primary drug resistance to start off with, some of the clearest mechanisms of innate resistance can be reconciled with our knowledge of cell signaling pathways, which you've been introduced to in Andrew Ward's lectures. So, for instance, in colon cancer, many cancers are driven by mutations in the EGF receptor. So this is the epidermal growth factor receptor. Now, it's important to note that the names here are not that important, but their effect on the cell are things that you've come across before. So either an amplification or an activating mutation in the EGF receptor instructs the cells to proliferate uncontrollably. So if you add a drug which inhibits the activity of the EGF receptor, it blocks the EGF receptor from signaling. So you would think that this would be very effective in colon cancers that harbor those mutations. Now, many colon cancers also have mutations in genes called RAS and PI3 kinase. Now, these are enzymes which normally transduce the signal from the EGF receptor into the cell and instruct it to proliferate. So if you happen to also have mutations in RAS or PI3 kinase, then that renders your EGF receptor inhibitor a lot less effective from the outset. Okay, so that's a difference in tumor genotype, which can cause innate resistance to your drug of choice. Now, another example is one where the patient genotype can cause resistance. So here is an example of chronic myeloid leukemia, which is often driven by an oncogene called BCR-ABL. So what happens here is that a fusion between two unrelated chromosomes causes the expression of a fusion protein. So it links two previously unrelated proteins and causes inappropriate proliferative activity in the cell. So a drug called Gleevec targets the BCR-ABL oncogene in CML, or chronic myeloid leukemia, and that stops its proliferative activity. Now, part of what the BCR-ABL oncogene does is causes the degradation of another protein called BIM, and that's what promotes cell survival. Now, if you put on Gleevec, normally blocking the BCR-ABL signaling causes accumulation of a protein called BIM, and that instructs the cells to die. So that's how your therapy works. Now, in 12% of East Asian populations, they carry a gene encoding a defective version of BIM. So when you add Gleevec to patients who have CML, who have a defective version of BIM, it has no effect on the cell death mechanism, and they're resistant to that kind of therapy. So the Gleevec doesn't instruct the cells to die. It still inhibits cell proliferation, but when you take the drug away, the cancer just comes back. So in contrast, mechanisms of acquired drug resistance happen during the course of the treatment. So they're not there from the outset, but they happen during or after drug exposure. So here it's worth remembering that cancer is actually a microevolutionary process. And we already know that the increased mutation rate in cancer cells makes them a moving target for therapy. They're constantly sampling new genetic variants, and the ones that are the cancer cells that are better at surviving will outgrow others in the population. Now, some of those are going to be resistant to any drugs that you put on the cells. Okay, so if I try and make that clear just by going through this diagram here. So the desired outcome is featured at the top here. So initially you have drug exposure of a collection of tumor cells. Now the drug will initially cause tumor regression, and prolonged drug exposure will continue to be effective until you have complete remission of the tumor. Now, what is more common for a single agent therapy is an acquired resistance outcome. Now that is where the drug is initially effective, and that causes regression of the tumor, but where prolonged drug exposure actually selects that small population of cells that have acquired resistance to the drug, and they're able to proliferate in the presence of drug. Now, in lots of cases, these cells can even become addicted to the drug. Now, what I mean by that is that the cells actually become reliant on the presence of the drug for survival, and we can turn that to our advantage. And we'll come to that in some of the supplementary information. In fact, a lot of my own research is focused on studying mechanisms of how cells acquire resistance to drugs and different strategies that we can use to overcome that acquired resistance in cancer. If we talk about mechanisms of acquired resistance, if we focus on conventional therapies for now, cancer cells can acquire generic drug resistance through a variety of mechanisms, so that this list is not exhaustive. But one of the major ways that they do this is by increasing drug metabolism. So that is the cells metabolize the drug, and the drug cannot hang around in the tumor for long enough to be very effective. The cells can also acquire the ability to inhibit drug transport into cells or increase the transport of the drug out of the cell once it's got in there. Now, both of those mechanisms stop the drug from getting to the places where they're going to be effective. Another major mechanism of acquired resistance is that which you've probably come across already, is that the cells can further inhibit mechanisms of programmed cell death, or also known as apoptosis. So I think we'll call it a day for drug resistance just now. So the big message of hope here is that combined therapeutics can overcome these drug resistance mechanisms. So a combination of conventional therapeutics and targeted therapies are looking to be, at least in laboratory trials, to be much more effective at subverting some of these resistance mechanisms. Now, we'll talk a bit more about targeted therapies in the supplementary information.